Hello, my name is Rivera. In this occasion, I'd like to present to you the following case related to a newly diagnosed systolic heart failure and arrhythmia in a 53-year-old patient with COVID-19 pneumonia. The COVID-19 pandemic has posed one of the biggest challenges in the history of modern medicine. The wide variety of symptoms in its presentation, the multi-system involvement, and its infectivity can make management of the disease difficult. Myocardial involvement in the context of a COVID-19 infection has been widely documented, with a variety of proposed pathophysiologic mechanisms. Many times, myocardial involvement manifests with life-threatening cardiac arrhythmias, arrhythmias such as transient high-grade AV blocks or transient complete heart blocks, as well as tachyarrhythmias, including atrial fibrillation, atrial flutter, supraventricular tachycardia, and ventricular tachycardia or arrhythmia. In a case series study of 187 COVID-19 patients in Wuhan City, found that 28% of the cases showed myocardial injury, which resulted in cardiac dysfunction and arrhythmias. In this context, we would like to present the case of a 53-year-old male with past medical history of hypertension treated with lisinopril who presented to the emergency services of one of our sister hospitals with complaint of abdominal distension, nausea, and productive cough, found to be positive for COVID-19. In the emergency room, he was hypoxic, his heart rate fluctuated between 131 and 144, and an EKG revealed an SVT pattern. The patient was transferred to the ICU, where a pharmacological cardioversion with adenosine was attempted. Initially one dose of 6 milligrams, followed by a second dose of 12 milligrams. However, this proved to be unsuccessful. An echocardiogram was also performed, which reported an ejection fraction of 10%, biventricular global hypokinesis, and moderate mitral and tricuspid regurgitation. Of note, this was a newly diagnosed heart failure. He was then transferred to our hospital, where he was again admitted to the ICU. The patient remained with hypotension and sustained SVT, refractory to several antiarrhythmic agents such as metoprolol, esmolol, and amiodarone, and in need of vasopressor support. Troponin 1 was measured on admission and 3 days afterwards, negative in both measurements. Ultimately, an electrical cardioversion was performed, a 200 joules shock was administered, and a normal sinus rhythm was successfully resumed with a subsequent hemodynamic improvement. Establishing a direct association between all cardiovascular events that occur in the setting of a COVID-19 infection and the viral effect in the myocardium remains a challenge due to the novel nature of this infection and all the variables that could potentially interact in the lead up to the event, be it systemic illness, comorbidities, adverse effect of drugs, or direct myocardial injury. Studies suggest that SARS-CoV-2 targets ACE2 receptors via its S-spike protein. These receptors are significantly expressed in type 1 and type 2 pneumocytes, as well as cardiomyocytes and endothelial cells. Our hypothesis for this case is a direct myocardial involvement by the virus, leading to the cardiomyopathy and dysfunction of the conduction system. And in the setting of hypoxia, increased inflammatory cytokines, and long-standing hypertension, this triggered the supraventricular tachycardia and subsequent heart failure. Reports highlight that most of the patients that developed serious cardiovascular involvement had elevated biomarkers such as troponin 1 and type B natriuretic peptides, among others. As discussed, SARS-CoV-2 seems to inherently present affinity towards the cardiovascular system. Therefore, it is increasingly important to consider this possibility as treating physicians in order to drive down mortality in high-risk patients. As such, we recommend routine troponin 1 and type B natriuretic peptide measurements upon admission on all COVID-19 patients. This will allow early identification of cardiac involvement and thus help guide management. Additionally, we recommend a thorough cardiac workup if there is considerable suspicion of cardiac involvement, including but not limited to transthoracic echocardiogram, CT angiogram, and cardiac MRI, regardless of the biomarker levels.